on varicose vein. I would like to welcome the presenters on stage, Dr. Asha Priyadarshini and Dr. Jansi Pagadam from Government Thoothukudi Medical College. I am honored to invite our beloved HOD Sir, Professor Dr. J. Jailal Sir, onto the dais to chair this session. May I also request Dr. Ajin Daniel Sir, Assistant Professor, Kanyakumari Government Medical College, to also chair the session. Thank you.
So welcome to this SCALPEL 24 program, and this will be an intensive postgraduate training program. So we have expert professors, Professor R.C. Sri Kumar and Dr. Professor Punithan will be joining with us in another 5 minutes. Since it has been brought across the state that we are starting on time. Audio is little. So the few cases we are presenting here, with the more discussions will be on clinical findings and the management of this. Though there are the two presenters who are presenting the case, I wish it should be an interactive session so that all the postgraduate here are able to ask some questions, and whenever you have a difficulty or at the end of the sessions that we will have a few minutes that you can ask some questions of the doubts, and for the way you wanted to see that you can ask that questions. So each case we have chosen the cases in the way that it is the most the common examination cases. The evening sessions, the late evening sessions for the audio. Ulcer and swelling, we will have different varieties of cases which you can discuss, or if you have any particular case to be discussed, and we will have some time for that we can ask some questions and so discussing on that. Since most of you in your routine ward classes in the college that you had exposed to a lot of time on the history and what are the changes, and we will not spend much time on the history taking. It will be mainly on the management part. So we have array of cases which are very common, which we start with the peripheral vascular disease, varicose vein, carcinoma of stomach, carcinoma of the thyroid, and soft tissue tumors, and even sarcoma we have kept because so that you will have a more knowledge and interaction. So I will be happy you all come actively participate in this session. So before going into the per se, because there is two more examiners, they are on their way, they are almost another 5 minutes we will be then. Can you speak for 2 minutes or 3 minutes, and what do you understand about varicose vein?
Subcutaneous elongated dilated tortuous veins which are about more than 3 mm in dimensions lying in the subcutaneous plane. Initially there will be initial presentation will be reticular veins or telling.
So any vein which is dilated tortuous, you call it as varicose vein?
No sir.
So that's the most important thing is a demonstrable reflux. So what do you mean by reflux?
Normally the blood will be traveling from superficial veins to deep venous system, but if there is reversal of flow, it is called as reflux. If the reversal is for more than 5 seconds, it is called as reflux.
So you are interested to see that if there's a vein dilated, tortuous, and if there is a reflux, then you are going to call it as a varicose vein. Okay, very good. Go ahead.
Initially, the patient may be having either reticular veins or telangiectasia. Telangiectasia or thread veins are they are intradermal veins which are about less than 1 mm in diameter.
How do you make a diagnosis, measure that? How do you measure? There is no clinical methods to diagnose, it is only approximately what we are saying. So the best way is only intradermal veins. The thread veins or the intradermal veins, that is in the vein, what you are going to see. Subdermal vein is a different one.
Reticular, about bluish.
Yes, the size is notified significant, but that is not the way that we are going to see that vein, whether the vein is in a filled state, whether the vein is in a closed state, we are not going to measure. It is most of the smaller veins that.
Varicose vein, etiology, the incidence of varicose vein increases with the age of the patient. If the patient is more than 50 years, there is 55% more risk of having a varicose vein. Obesity is one of the factors.
You mean to say the obesity is the cause for the varicose vein? Someone who is very tall, and then another one is a very short individual who is more prone to have a.
Individuals are more prone for having a varicose veins, sir.
Why?
Hydrostatic pressure, the pressure column of blood from the level of heart to the foot is the hydrostatic pressure. So that will be more in tall individuals.
So what is the difference between oncotic pressure and hydrostatic pressure? Or osmotic pressure? So what determines the osmotic pressure or the oncotic pressure? Very good. It is the proteins which you are having in the body. There's a lot of things which are there. But here it is not the proteins which you are going to measure. It is mainly because of the hydrostatic pressure, the column of the length. Okay.
More prone in females.
Why in more from females?
Progesterone acts in the smooth vessels and causes dilatation of the vessels, so they are more prone to get a varicose vein than males.
Is it progesterone? So which hormone will produce more ectasia of the vessels? In a liver cell failure, there is estrogen excess, you get spider nevi, vessel dilatation cell.
Is it more common during pregnancy or is it more common in the
More common in pregnancy, sir.
So hormones plays a role. It is not purely a progesterone. There is hormone that plays a role because the vasodilatation it is taking place. So
Females are more prone than males.
no, so what? Why you get varicose vein?
Is it a functional reflex or what? What happens?
Functional.
What do you mean by that?
No obstructions, sir. The dilatation of vessels are due to the smooth muscles.
No, I agree on that. You say there is a dilatation, but why there is reflux? Anybody? See, you have a walls like this. The walls cannot stretch. So now this valve is closing, but my vessel is going for dilatation. This valve, normal valve, it cannot close. It can only stretch to the particular level. So that is the reason why when the veins go for dilatation, even if you have a normal functioning effective valve, it cannot occupy. Even if it is tightened, it cannot occupy. There will be some narrow part will be there. And that is the reason why that you are going to get that. So you get, and somebody comes to you with a varicose vein to you, that how do you approach him?
Clinical examination.
Straight away you will go for a clinical examination.
First, we'll ask for the history, sir. Whether the patient is symptomatic or whether the patient is having only the dilated vessels or other patients.
So one person is having a symptom, one person is having no symptoms. What you will do?
Patient is not having symptoms, probably you would have come for cosmesis, sir. We can give a reassurance and give non-surgical conservative methods like after confirming.
So when there is no symptoms, you will not treat. We are not starting the case. We start the case. uh, uh, so patient comes to you with symptoms, without symptoms. What is your approach?
Even if it is asymptomatic, if patient was want cosmesis, they can get.
Varicose vein, the people come to you for a
Dilated.
cosmetic purpose.
If there are multiple dilated tortuous limbs,
So you are going to treat only on the basis of a cosmesis.
symptomatic pain, lipodermatous.
No symptom for him. Today he has come to you without any symptoms.
If untreated, it can lead to chronic venous insufficiency.
No, my asymptomatic varicose vein, whether you advise surgery or you advise follow-up.
Follow, we can do follow with compression bandages.
How many percentage will lead to complication over a period of time?
20.
So what is the advice you will give? One is
So
symptomatic, one is non-symptomatic.
So compression bandages can be advised for the patient, and limb elevation can be advised. Compression bandage can be crab bandage are present, and then elastic stockings or pressure stockings are also available. Then limb elevation can be given for the patient advised.
How do you decide and what compression stockings you will give?
So there are basically three, according to British classification, there are three from 14 to 17 class 1, 17 to 24 class 2, and 24 to 35 class 3, sir. So if the patient is having no symptoms, we can give for class 1, sir. For post-op cases and pregnancy and all, we can give class 2, sir. The patient is having complications like ulcer and all, we can give 40 to 45 can be
Anything else you measure?
Yeah. What is the
so we should
contraindication?
rule out PVD before giving all this.
Brachial pressure index can be. Ankle brachial pressure
Palpate
index
the
can
pulse.
be. Pulse.
The pulse is palpable, you can very well apply the bandage. Pulse not palpable, then you do
ABPA.
Right. If it is less than 0.5,
Critical
no.
limit.
Less than
Less than 0.3 is critical limit.
0.5 ischemic change some options.
needs revascularization before applying the bandage.
So somebody has a pain as a feature. So how will you rule out this pain is only due to varicose vein, not due to other reasons?
So varicose vein mainly due to visceral, due to the stretch of veins, visceral pain is present in which produces
So what do you mean by visceral pain?
So stretching of the vessels causes the tension of the
No,
vessel.
what do you mean by visceral pain? What do you mean by skeletal pain? What is pain? Pain is a reflex, no? There must be some pathway must be involved.
Gateway.
So visceral pain is from which nerves are involved, and the skeletal pain, what nerves are involved? Autonomic nervous system, visceral pain. Skeletal nervous system, skeletal pain. So what are the stimuli which can cause pain in a visceral pain? So both skeletal pain and visceral pain has a difference in nociceptive stimuli, the pathway, the character features. So when you say visceral pain, what can cause visceral pain? Can you cut the vein? Will it be painful?
No, sir.
It will not be painful. So what is the nociceptive stimuli? Either the stretch or a collapse.
Okay.
These two only ischemic collapse, something happen, is stretch. So that will be. So what is the character? Then difference between skeletal pain and visceral pain.
Dull aching.
Dull aching. So you can get a colicky pain also in the viscera. Viscera, you have a uretary colic, you have a biliary colic. Can you localize the pain?
Visceral pain can't be localized. Visceral pain can't be localized.
Can't be localized. So where do you get the pain? Suppose you get a visceral pain, where do you get the pain? In the abdomen, if you get a visceral pain, where do you, the pain will be localized? So if the stretches are coming from the foregut, the pain will be in the epigastrium.
Midgut, umbilicus, hindgut, suprapubic.
So here you are going to have because the stretch of the fibers, you are going to get the pain. So what my question is, then patient says the pain, how we are going to differentiate? It is only varicose vein, not other pain.
Sir, in varicose vein, we can ask if the patient, the pain is relieved immediately on taking rest, it will be arterial, sir. If the patient is taking some time for the pain to get
It is
relieved.
not, we are not asking for the claudication pain. We are not, never use the
Yeah.
word claudication pain to find out whether it is this and that.
Okay, sir. Crampy pain, arterial, sir. For DVT, it will be a bursting type of pain, and for neural shooting type of pain will be there, sir.
So what kind of questions you ask to the patient? Suppose he says and he has a pain. What are the questions?
When is the pain getting aggravated? Walking, is it getting aggravated? When it is getting relieved? If when he takes rest, it is getting relieved, or when he elevates the limb, it is getting relieved. You can ask such leading questions.
What is venous claudication?
Sir,
Obstruction of the venous. That is a deep vein thrombosis, you get an obstruction. That we don't call it as a claudication pain typically. So will the pain will be relieved in a deep vein thrombosis?
No, sir. Pain won't be relieved.
post-thrombotic.
Very good. Post-thrombotic vein.
Post-thrombotic vein, usually when the patient, there will be formation of collaterals, sir. So when in rest, it can be compensated by the collaterals. But once the patient is having any activities, there will be lots of blood inside the limb. So that much venous return should be also compensated, which cannot be
one is
compensated by
collateral,
the
second one
collaterals.
is impartial or not a complete thrombolysis. Recanalization may not be complete.
Okay, sir.
There will be partial recanalization will be there. So that amount of blood can be transferred. But once he is working hard, that it cannot be
Compensated by the collaterals form.
Oh. Now you can start with ready with your case? Okay, you can start with the case.
Good morning to one and all. We are going to present a case of varicose veins. Our patient is a 75-year-old patient named Mr. Sudlai Mani, who is a farmer by occupation. He came to OPD with chief complaints of dilated and tortuous veins over left leg since 2 months, and there is associated pain over the left leg since 1 month. History of present illness. Patient had history of dilated and tortuous veins over the inner aspect of the left leg for the past 2 months, which are progressive in nature. They become prominent on standing and less prominent on lying down, associated with pain over the left leg since 1 month, which is of dull aching type, aggravated on prolonged standing and is relieved by rest. There is no history of night pain, no history of itching, no history of swelling, no history of skin discoloration, no history of ulcer, no history of fever, no history of prolonged immobilization is present, no history of abdominal distension, no history of constipation and trauma, no history of breathlessness and chest pain. Past history, patient is a known case of coronary artery disease since 15 years and is on medication. Patient is a known hypertensive for 1 year and is on medication and is under control. No history of similar complaints in the past. No history of any surgeries in the past. Not a known case of diabetes, asthma, epilepsy and tuberculosis. Personal history, patient takes mixed diet. He is not a smoker and not an alcoholic. There is no history of any allergies. Bowel and bladder habits are normal. Family history, no history of similar complaints in the family. Summary, a 75-year-old male with chief complaints of dilated tortuous veins over the medial aspect of left leg for 2 months and associated with dull aching pain over the left leg for 1 month without any complications, probably due to varicose veins of left lower limb involving great saphenous venous.
Vein itself a complication, no? What is complicated varicose vein? What do you understand?
Ulcer lipodermatous.
What do you mean by complicated varicose vein?
Varicose vein leading to chronic venous.
Asymptomatic means without symptom. All the others are complicated varicose vein. Pain itself a complication. Pain, then
Ulcer, edema, lipodermatosclerosis.
Edema, lipodermatosclerosis,
Pigmentation over
pigmentation, ulcer,
ulcer.
bleeding. All those are equinus deformity, periosteitis, calcified vein, thrombophlebitis, everything are complications. What is the take-home message? When there is a complication, patient need
Surgical management.
some intervention.
Intervention.
Asymptomatic varicose only, sir was asking what will you do? See, 33% of the asymptomatic varicose vein on 10 years of long follow-up, they develop complication. The previous Bayesian law edition says you have to do surgery because earlier you do the surgery, better will be the result. Earlier you intervene, better will be the results. So regularly some vascular surgeons they advise surgery for asymptomatic varicose vein because the success rate is little high. Once you develop complication, success rate is little. Yes.
Okay, what are the cause of pain varicose vein? So there is pain.
You told me causes for pain in the varicose vein.
Due to stretching of the vein tension over the wall of the vein, due to changes in microcirculation, aggregation of the erythrocytes.
What changes in microcirculation?
There will be aggregation of erythrocytes and there will be...
Why there is aggregation?
Due to increased...
Due to?
Inflammation.
Why there is inflammation?
Due to chronic vein...
if vein is simply dilated, why causes inflammation then?
Due to chronic venous hypertension, there will be stasis of the blood and neutrophils will be marginalized to the...
What is the normal pressure? Normal venous pressure?
Over the foot, at the level of foot, it is 100 mmHg, sir, while standing.
All veins, physiologically?
At the level of capillaries, on arterial end, it will be 32, and whereas on venous end, it will be 12, sir, 10 to 12 mmHg.
Okay, 10 to 12 mm. Okay. Once it becomes 100 only, this becomes venous hypertension. Okay, how it differs from pain in an arterial disease?
Arterial disorders, due to reduced vascular supply, there will be chronic reduce in blood supply and there will be anaerobic metabolism and which leads to pain.
Okay, from the symptoms, how can you say that it's a venous pain? What are the features of a venous claudication?
Venous claudication.
Arterial, when the patient takes rest, it will be immediately relieved in arterial cases, whereas in venous claudication, it will take some time for the pain to get relieved. And when the patient is elevating the limb also, the pain decreases in venous, whereas in ulcer, it will get aggravated.
So pain is basically in the beginning of walking in a case of venous, and is more towards walking, more walking, arterial pain happens. Site-wise? Common site of venous claudication.
Peripheries towards the digits, it is arterial pain, sir.
Venous?
Especially digits.
Venous, lower leg and calf region. There will
Not calf region.
Lower 1/3 of the leg.
It's mostly around the knee joint, just below the knee joint. It is. Okay.
Per minute, regular in rhythm, normal volume felt in all peripheral vessels. Blood pressure is 120/80 mmHg, measured in left upper limb in sitting posture. Respiratory rate is normal. On inspection, after getting informed consent, patient exposed and examined in standing position. Multiple dilated tortuous vein seen over the medial aspect of left leg, extending from the ankle up to upper 1/3 of the leg. No skin discoloration or edema over the left leg. No ulcer noted. No redness. No scars seen. No loss of hair and brittleness of nails. No deformity present. Palpation, no focal rise of temperature, no tenderness, no ulcer, no lipodermosclerosis. And test, Brody Tendelberg test 1 is positive, which indicates SFJ incompetence, and Brody Tendelberg 2 test positive, which shows that the perforator is also incompetent. Morris's cough impulse is present, which says that the SFJ is incompetent. Multiple tourniquet tests, there are prominent veins seen in the region of below knee perforator and above ankle perforator. Fegan's test is present, the defects are present, felt over the upper 1/3 of the leg below the knee. And Schwartz test, impulse not felt on saphenofemoral junction when percussed below. Examination of other limbs are normal. So this is a multiple tourniquet test. Sense.
How many tourniquet you time?
Sir, SFJ
3 tourniquet. One is,
below the SFJ, sir.
that is not seen.
Yes, sir.
3 tourniquet only because you have 3 tourniquet with you, or
5, actually 5 can be, 4 or 5 can be, sir, above ankle.
if I
One
put
is
10,
below the saphenofemoral junction, one above and below the knee, above ankle, and
if I put 10, what happens?
sir,
If I am putting 10 tourniquet, is it good or bad?
accurate perforator can
Yes.
be
Yes, if you have more.
Location of
perforator can be seen accurately. By removing from below each tourniquet, we can see the position of the perforator.
How tight it is? There is a tightening device there. How tight it is?
Superficial system should be occluded.
just to occlude the superficial
superficial
system, not the
deeper system.
deep.
Deep and artery also. Okay.
Super grades of yes, sir.
Those dilated veins you see, right?
Yes, sir.
What are they?
Superficial.
Yeah, but what are they?
GSV and second collateral.
Which one will varicose means become tortuous more? A GSP or a tributaries of a GSP?
Tributaries will be more tortuous.
So what we see is the tributaries.
Tributaries.
And is it the GSP?
Yes, sir.
Can it be a?
It can also be anterior accessory saphenous.
Or posterior accessory?
Posterior accessory saphenous.
What is that? Otherwise called? So mostly those will be the incompetent perforators. Cockets perforators.
Cocket.
What we see in the below knee position.
Right.
Between the posterior tibial vein and the posterior accessory
Posterior arch.
vein, or the arch vein of the anatomy. So GSV might be just dilated and might not be visible also in this case.
When will you say a perforator is incompetent by doing a multiple tourniquet test?
In between the tourniquet, we should see the and we will try to remove the tourniquet above. We will try to remove the tourniquets and position them accordingly. And on putting the tourniquet, if they are getting dilated, they are present in between the tourniquet.
Yes. One important thing is vein should be emptied before doing a multiple tourniquet test. That's a must. And second thing is you can apply any number of tourniquet. There is no restriction that it should be 1 or 2 or 3. If you apply more and more tourniquet, your accuracy will be much more, because these tests are being used before ultrasound is more popularized. Third thing is it should be as tight as to occlude the superficial veins, but should not occlude the arterial and the deep system. Okay? If the arterial is occluded, then no blood will come. And the deep system is occluded, then it will convert from this deep to superficial system. Okay? And fourth thing is when it's a positive, if there is any segment of vein is dilated between 2 tourniquets, that means the perforator corresponds to that area is incompetent. So these are the 4 or 5 points related to this test. Okay. Yes, please.
Yes, sir.
You said you did the Brody tunnel test.
Yes, sir.
1 and 2.
Yes, sir.
In the thigh, which vein did you observe?
GSV.
Is it visible?
No, sir. No, sir.
There
Yes,
is no
only
vein.
below the knee it was
There
getting
is
filled, sir.
There is no vein visible in the thigh.
Yes.
Right? Then how did you check Brody Stellenberg 1?
Filling was there below the knee alone.
That might be because of a perforator.
Okay, sir.
So how can you come to the conclusion that SF junction is incompetent? You can't see the GSV itself, then how can you check the cough impulse? Do you think that it will be positive?
Sir is saying you have to say it's positive if it fills within 30 seconds. If it fills after 30 seconds, it may be due to some perforatus. And upper segment is not visible. Any vein, normal vein above the thigh may not be visible.
Okay, sir.
So it's how do you say it? Yes. Answer it and go.
This Trendelenburg 1 and Trendelenburg 2, these tests are obsolete. Even in Bailey says it is obsolete. So you do clinically, you find incompetence, well and good, we will accept. But now everything based on venous duplex. So the duplex fellows are a weekend vascular surgeon, as we ourselves do the duplex and find out the reflex. What are all the tests you are doing here, no, to find out saphenofemoral incompetent Trendelenburg 1, that can be seen in duplex. You see perforator incompetent, each and every perforator we can use duplex and find out the reflex. And the deep vein thrombosis, whether it is patent or not, that also we can do duplex, and whether vein is compressible or not. We can differentiate acute DVT and chronic DVT using the same venous duplex. And saphenopopliteal junction, which is other small saphenous vein system, no, that incompetence also we can identify by doing venous duplex. So that saphenopopliteal junction incompetent, that DAS says in between the second and third tunica, if there is a bulge, you can see the saphenopopliteal junction. It is variable, the position is not there. So basically this test soon, in the 5 years, even current Bailey says it is obsolete, not done. So I don't know whether...
Just for exam purpose, we are discussing it.
Yeah, we are discussing.
Then that's 1 and 2 is test is there. How to do modified that's Schwartz that test 1 and 2, Trendelenburg?
So first we ask the patient to lie down in the supine position. We elevate the limb and empty the vessels, sir. Then
No. Trendelenburg. Just for exam purpose.
Yes, sir.
Sir said most of the tests are obsolete.
Yes,
We are
sir.
not treating any patient on this test. But
Okay, sir.
just to pass the exam, you should know all these things,
Okay,
especially
sir.
an old exam.
Yes, sir. So we are tying a tourniquet below the saphenofemoral.
Okay.
After emptying, we are tying a tourniquet below the
Trendelenburg also you put a tourniquet there.
Or we have to
Can you
occlude with our
where are you occluding?
saphenofemoral junction.
You can occlude the tourniquet there.
Below the saphenofemoral junction, we can put tourniquet.
Okay.
And we ask the
How will
patient.
you identify saphenofemoral junction?
So it is 2.5 centimeter below and lateral to the pubic tubercle, sir.
How do you identify pubic tubercle?
The adductor, we can adduct the thigh of the patient, and we can, it will be tensed, so we
Yes.
can trace and go to the pubic tubercle.
Which muscle?
Adductor longus, sir.
Okay.
Then we ask the patient to stand, sir. For Trendelenburg 1, we have to remove the tourniquet. So as soon as we remove the tourniquet, if the veins are getting filled
That-
immediately,
okay.
it is one
Fine,
positive,
good.
sir.
2?
2, gradually. We don't remove the tourniquet immediately. Even with the tourniquet, there will be slow filling of the vessels, which says the 30 to 60, after 30 to 60 seconds, sir.
Okay. Okay, fine. Go ahead. Go ahead.
You have not put the modified Perthes, no?
No, sir.
Is it purposeful or anything?
No, sir. DVT, to rule out DVT, but patient did not have any symptoms for DVT.
How many of patient, your DVT patient have a symptom?
Should have done that. Sorry, sir.
That is the most important test
Yes.
from clinician, because if
We have
there
to
is
rule out
DVT,
DVT, then we have to proceed to other tests. Yes, sorry.
DVT is a absolute contraindication to do regular procedures.
Yes, sir. Okay, sir.
No, I thought that you have purposefully did, because somebody will say when the perforators are incompetent, what you are going to see in the modified Perthes test?
Whether patient is having DVT or not, we'll ask the patient to walk with...
So what will be there? What will be the finding?
If the
Bursting type of pain, and well as the vessels will become more prominent.
So will in the perforators incompetence, vessels will become prominent?
vessels will collapse, sir, in case of perforator.
When the perforator is incompetent, you will similarly you will get the bulge.
Okay, sir.
So there is one argument says, and if you are going by the seeing the bulge, don't do the modified Perthes. But
Okay, sir.
definitely you will be able to differentiate with the pain and the things, and that is one of the most important tests.
Okay, sir.
So how long you will ask the patient to walk?
3 minutes.
Brisk walk for...
You have only 40 minutes.
Okay, sir.
Ask the patient to walk.
5 minutes, brisk walk for 5 minutes.
He will go walk out of the department. What?
Tiptoe movements can...
Tiptoe
at it.
movements,
Okay.
Yes, sir.
Okay, what's the only test you do without emptying the vein?
Schwartz test.
Schwartz test.
Yes.
Okay, what indicates what?
It's a SFJ incompetence.
No.
Chronic...
If any valve is incompetent, we can elicit a Schwartz test.
If the
Any valve is incompetent, you can block one segment and tap it. Tap it. Any segment of vein can be examined for any incompetent valve in between. Okay, Schwartz test. Okay, fine.
Sir.
Yes. With any ulcer or something?
No, sir. This
Any
patient...
changes in the skin? Nothing
No,
is
sir,
there.
no,
Okay.
sir.
So
Put the next slide and you have put this, no lymph node is palpable. What is that?
No, sir.
No, what do you mean by that? No lymph node is palpable means? Lymph nodes-
Inguinal, sir. In case of ulcer, patient might have vertical lymph node enlargement.
So you examine the vertical lymph node.
Inguinal
lymph node.
Quick yes or no, there's nothing wrong in that.
yes or no?
more than 2 centimeter is significant, sir, for inguinal nodes. Okay, sir. Not significant lymph
Significant lymph node is.
Okay, sir.
If it's a 1 centimeter node, it's a different area, which is hard in consistency, significant or not?
Cervical...
No, lingual region, very hard node, 1 centimeter.
Sir, if the,
Criteria.
we can use...
Size is not only criteria. If
It's not the only criteria.
consistency also, okay, sir.
any hard node is significant.
Okay, sir. Okay, sir.
Okay.
Significant nodes, hard node,
Fixed node.
Fixed nodes,
matted
more than
node,
200
tender node, supraclavicular node, size more than 2 centimeters.
Okay, sir.
Okay, that's it.
Supraclavicular node. Normal lymph node is palpable or not palpable? Normal lymph node.
normal node
It
is
has not even like no inflammatory change, nothing. It's only a normal lymph node.
Normal node for you, is it palpable or not? Or a thin individual?
Palpable.
No.
not palpable.
Okay, sir.
Loss it is clearly never palpable unless it is enlarged by
Okay, sir.
some infection or
More than
some benign or malignant.
It may be significant is a different question. But
Okay,
it is
sir.
enlargement, unless it is enlarged, you will not be see.
Okay, sir.
Normal nodes are not palpable. All palpable nodes are not significant. Okay?
Okay, sir.
Significant nodes are evaluated.
Okay, sir.
Okay, fine.
Okay, sir.
So, anything else in the examination? Any other area do you examine?
Abdomen.
Yes, abdomen. What all things you look for? Why you are examining abdomen?
So, sir,
Abdominal or pelvic tumor can lead to secondary varicose veins.
Yes. Okay.
pelvic tumor.
Okay. So, everything is normal.
Yes, sir.
Abdomen is
So, what do you do now?
So, I'd like to confirm my diagnosis with duplex scan, sir.
Okay. Have you done a duplex? Have you seen doing a duplex?
Yes, sir.
Okay, very fine. So, what all things you look for the duplex?
So, we see reflex, sir.
How do you see a reflex?
for more than 5 seconds if there is
Where?
Size and
Where?
for
SF.
SF junction.
no, sir. For perforators, it is more than 0.3, sir. 0.3
Okay.
seconds, which is significant. For other veins, it is 0.5 seconds.
Okay.
Sir.
How will you elicit the reflex?
Sir, augmentation we can.
How do you augment?
We can squeeze the calf muscles, sir. It can. If we distal to the veins, if we augment and leave, there will be flow, sir. And this, proximal to the vein, if we press, there will not be augmentation. If it is there, it signifies there is a reflex.
SF junction, how do you augment? How do you check for reflex? Pressing on the calf will not reach there very easily. Any other
Plantar
method?
flexion, dorsiflexion and plantar flexion. Alternate.
Valsalva maneuver. Okay, sir. Valsalva maneuver.
Yes. How do you do a valsa?
Ask the patient to blow against
Closed mouth. Okay, fine. Okay.
nostril and mouth.
Okay. So if there is more than 0.5
What sound you are going to use for doing a duplex?
Ooh, sound.
No, what you are going to use? You are going to use an ultrasound, no?
Yes, sir. B mode ultrasound.
B mode ultrasound with
B
Doppler.
mode for what? What is that B stands for?
Brightness.
Brightness mode.
Is it a continuous or you are having a pulse ultrasound where you are going to use?
Phase, mono.
Are you going to use a continuous wave?
Pulse.
Pulse.
Pulse wave.
What is the difference in pulse wave and the continuous wave?
Pulse wave artery will be showing triphasic waves, sir.
In
And
reflex, there will be
rapid
biphasic.
antigrade flow. In venous system, there will be biphasic flow, sir.
Venous system?
Monophasic, but in reflex, there will be biphasic flow.
Now, how do you know that you are sending a wave?
Yes, sir.
Up to what level the artery will be reflected? There are a lot of arteries. No? Even subcutaneous, there is artery.
Yes, sir.
There is a deep, there is artery. How do you know that it is only the femoral artery is reflecting the sound, not some superficial artery vessels are coming out?
Or simply, how do you differentiate a vein and artery? That's our question.
Towards
Towards the heart.
red flow will be red in color. Away from the heart it will be blue in color.
That's one thing. More than that, you put the probe on that femoral area, you see that femoral artery and femoral vein is there. How will you differentiate these two?
Compress.
Okay, yes, you're right.
Compressibility, veins will be compressible.
Vein is always
Whereas
compressible.
arteries will not.
Vein is always compressible, artery is never compressible.
Okay.
Yes, that's one. Then,
Phasicity.
yes,
Phasicity. With the respiration, there will be augmentation.
phasic variation, augmentation in a vein or artery?
Vein.
Vein. Third.
Patency.
Patency, both are patent
Yes,
or
sir.
both are occluded? One is pulsatile, one is non-pulsatile. Okay?
Artery is
When you put a pulse mode over it, artery shows pulsatile. So always you should differentiate an artery and a vein in ultrasound or a Doppler. One is, vein is always, if you apply pressure, vein gets compressed. Artery never gets compressed. Flow is always pulsatile in artery, then vein is not pulsatile. And if you do a Valsalva or some variation, that will not affect arterial flow, that will affect the venous flow only. These are three features by which you have to differentiate. Always it is important because when you are puncture the vessel also, very careful about it, vein or artery. So you should identify as a vein or artery. Okay, fine, good. Then. Okay, by doing a Doppler in the SF junction, one is reflex, anything else you look for?
Size.
Size. Why size is important?
Sir, if the size is less, we can go for ablation procedure, sir. If it is more than 15 mm, ablation procedures will not be that effective, sir. So we have to go for surgery, Trendelenburg procedures.
It's a relative content, we'll come it later. Relative content, there are many ways to do it.
Okay,
How do you look for the size? What's the position of the patient?
Suffice.
line.
Stand.
Stand.
Standing reflex.
Standing position.
Ideally.
Standing position.
Yes. Particularly if
Deep
you are
vein,
looking, yes.
supine positions.
Particularly if you are looking at the size of the superficial vein, patient should be on standing position.
Okay, sir.
With standing, it increases or decreases?
Increases.
Increase always. Okay. Okay, that is the junction. You have to look for the reflex, then size. Of the GSV.
Yes, sir.
And you have to look at the position of the GSV also, because if you are doing a ablation, you should know exactly where it comes. You should have some idea about it. Okay. Then, how do you know that there is DVT or not by doing a Doppler?
If there is thrombus on compressing, there won't be complete
Compression.
we can't
Non-compressible vein.
Non-compressible.
Yeah.
Yes.
Okay.
Then, vein.
Can you differentiate acute and chronic DVT and duplex? Other findings.
Yes.
Acute
How do you say it's
DVT?
DVT? One is compressibility, then all normal veins should be compressible. There should be phasic variation, there should be augmentation. If there is phasic variation, augmentation absent, that indicates a DVT.
Okay, sir.
And if there is any foreign body inside, seems it's like it's a suspect DVT. Then sir is asking, okay, if an DVT, sir is asking how you can differentiate between acute and chronic DVT.
Acute DVT, completely occluded vessel will be. In chronic DVT,
It's a high volume thrombus, not properly treated. Chronic also can be.
Collaterals will be found in
Chronic.
Chronic, you will see collaterals.
Collaterals.
Acute DVT, you will not see.
Collaterals.
Why it's important to differentiate these two as a clinician?
acute DVT is an emergency.
Yes. You have to treat acute DVT
Acute
immediately.
DVT treatment is
No reassurance and conservative management.
Limb elevation crab bandage can be used for chronic.
Fine.
lifelong.
Lifelong. Yes.
Lifelong.
It is harmless. It's a chronic DVT, no problem.
We should give lifelong anticoagulant should be substituted.
No, chronic.
The most important is your
Only
compression
crab bandage and limb elevation.
Ankle exercise.
Yes.
If it is a provoked DVT will give for around 3 months.
Distal
If it
for
is
distal
What is
DVT
provoked
is a
DVT?
3.
What is provoked DVT from the audience side?
Audience, provoked, unprovoked.
Last row audience.
We are provoking you.
What do you mean by provoked DVT? What is unprovoked DVT? Quick. Time is late.
Yes, please. Good. Unprovoked, there's no cause.
So it is without cause, unprovoked. Can you tell some example for
Yeah.
provoked and unprovoked? Anybody else? Louder. Oh.
That is unprovoked.
That is unprovoked, ma.
Provoked.
History of surgery or
Surgery,
immobilization will be
immobilization,
Risk
trauma.
factors
Okay.
are
There is
age
some
mo-
provocative fact like outstanding hospitalization, some trauma or fracture, patient is hospitalized, some plaster of immobilization. These are all provokings. Okay. That means there is a less chance of having a underlying cause like a protein C, hypersomos, anemia, or APLA, something like that. Okay. So it's a provoked DVT before?
Provoked DVT, there will be some history of
Okay,
immobilization.
okay, that's all. Sir is asking how you
How
treat.
long you treat
3 months, 3 to 6 months, and unprovoked will give lifelong treatment with
Treat with what?
warfarin lifelong. Initially, we'll start with
Start with
heparin,
heparin,
and
then
we'll
we'll
bridge with
bridge.
warfarin. And
Any newer
warfarin-
drug is there or still you use warfarin?
Rivarox.
Patient is
Rivarox
saying,
bands can be used.
So what is the advantage?
rivaroxaban and dabigatran.
Dabigatran.
less
Apoxifen.
monitoring.
What is the advantage?
Oral.
Both are oral. Warfarin is also
Warfarin
oral.
also oral, ma.
Less risk of
Yeah.
bleeding
Bleeding
disorders
disorders.
in
Correct. Less
New
risk
Year's.
of bleeding.
Bleeding.
And you need not go on
Monitoring
it.
monitoring it.
Dabigatran.
cannot be done. So suppose is it important that when the patient is coming to your surgery, if somebody is on warfarin or rivaroxaban, will you do the surgery or you have to stop the
We
drug?
have to
Stop for
the
5 to 7 days.
INR should be brought to around 1.4
1.4
before doing a surgery.
Surgery. 2 to 3
2 to
for
3
anticoagulant.
warfarin.
2 to 3 for?
If the patient is on anticoagulants, so we should maintain it for between 2 to 3, sir.
In congenital hypercoagulable state, it will be 2.5 to 3.5.
Okay, sir.
Congenital hypercoagulable state, if it is proven,
Okay, sir.
then 2.5 to 3.5.
How much will you give on day 1?
Day 1, 10 mg, we'll start with warfarin 10 mg, and based upon APTT, we can decrease.
Day 2?
Day 2, 10 mg, sir.
Day
Third day,
3?
we'll go for 5 mg.
Every third day we do PT, sir.
okay, we'll come back to varicose vein.
You said external genitalia is normal. What you looked into?
Sir, the
We can
varicosity
look at varices in vulvar region and
Okay, patient has
varicose.
a patient has a great. This patient is varicocele with a varicose vein. Does it value to do anything else?
renal artery hypertension can be present. So we should do a USG abdomen and rule out any renal causes.
Renal vein. There's renal vein compression may be there. So ultrasound is a must before proceeding if the
What is maintenance?
varicocele and a varicose vein.
Methana. So
What
it
is
is the occlusion of left iliac, common iliac vein by the right common iliac artery, sir. So it is one cause for varicose vein.
You are more concerned with the left side varicocele or
Left, more common is
more
left.
common on left side. If it is
with the right or left?
right side,
You have a reason for even normal sometimes the left side you can't get. But the right side is always indicate there is something
More
wrong
of
with
pathology.
that. Either you have to look in the retroperitoneal tumors,
Okay, sir.
the sarcomas compressing upon that veins you should look.
Okay, sir.
So always you have to examine the varicocele also when there is a varicose vein. If there is varicocele, that indicates a higher occlusion. Before you treat the patient, rule out.
Can you get an isolated varicose veins other than the saphenous vein?
yes, sir. If it is along the isolated anterior saphenous vein can get enlarged.
Enlarged.
Lateral aspect of
Superficial epigastric vein can get
Superficial.
enlarged. So we are running short of time. So how you are going to manage now?
management. We can go for either open.
Another 10 minutes for management. So
Okay. So this
Always open
After
patient is
discussing
saying, I
the
am a film artist, I don't want any cuts or.
We can go for
ablation
laser ablation or radiofrequency ablation.
Okay, what are the contraindications?
In case of DVT, it is contraindicated. Large varices, it is not
more tortuous,
indicated.
more tortuous,
Yes.
large veins more than 15 mm.
Especially saying 20 mm, you said it's 20 mm. Will you straight away go for surgery or any other option? Why laser is contraindicated in the case of dilated veins, huge dilated veins?
Not effective.
Effective ablation.
How it's not
Because
effective?
It will be
normally
apart from the fibers will not be able to ablate the whole of the veins adequately.
probe can't come in contact with the wall of
Then
the
what happens?
wall of the vessels.
Probe is not in contact with the venous walls. What happened then? What's the problem there?
Risk of
Recurrent
risk of
If there is,
thrombosis.
if it's not touching the wall, what will be formed in between?
thrombus.
Thrombus
Thrombus.
is formed. And if thrombus is formed, acute complication, long-term complications. What are they?
Sir,
Thrombus is formed.
Yes, sir.
thrombus.
You came out. What's our acute complication?
It can be of 4 types. If it is type 1 and type 2, where there is less than 50% occlusion of the common femoral vein, we can go for conservative management, sir.
No,
We
sir.
can call out
You have done a laser. It's not completely obliterated. It's a thrombus is formed.
What are the what are the complications of this thrombus? Acute complication, long-term complication.
white
DVT, and if it is
Not
going,
DVT, the superficial vein.
okay,
You are not going to the deep vein, no? You are
Okay,
the superficial vein.
superficial.
For
Only
time
superficial
constraints, I
thrombus
can say that if there is that acute problem, it can have thrombus and embolize.
Okay,
later,
sir.
okay?
Yes, sir.
And, and if it's not embolizing in long term, this gets absorbed. Thrombus gets, then recurrence is there.
Recanalization and then repeat.
recurrence.
So because of this acute and chronic problem, if the size is larger, it is not ideal. Okay, patient insists that mine is 20 millimeters, still I want to do laser or RFA. Any solution for that?
Sir, we can
Catheter assist.
We can catheterize.
Catheter assisted.
sclerotherapy.
No.
Listen,
You can give a tumor anesthesia around the vessel.
Around the vessel, so that can be
yes, the size.
opposition of the vessels will be more with the use of tumescence.
Yes.
It
With ultrasound guidance, you can inject tumescence around it,
Okay, sir.
and so that the vessel size can be reduced and do it.
Okay, sir.
But it should be properly done. That's very important. For a beginner, it might not be ideal. But if you are experienced, you can do even for a larger vessel. What is tumor anesthesia? What are the components?
So ringolatrate or ringolatrate with 1% lidocaine with adrenaline and sodium bicarbonate.
Okay. Any other local anesthetic agent? Better one. Lidocaine will act only for 1 hour. If you can ask for a long-acting one, you get
Bupivacaine.
24 to 48 hours. Better go for a long-acting or a mix of lidocaine and a bupivacaine.
Bupivacaine, okay, sir.
Okay, fine. Okay. What do you have to do that perforators?
we can sclerotherapy can be done, sir. Foam sclerotherapy of perforators can be done.
Yes. What is foam sclerotherapy?
Sodium tetradecyl sulfate is combined with using Tessaris technique will
How much air?
create a foam.
How
sir.
much air?
In
1:4
or
ratio.
1:3 ratio will combine, and this foam is injected into the vein, sir. After canalization of the perforators, we'll inject the foam, sir. 3%.
Will you put a bandage?
Yes, sir. Immediately after this, we should press the vein so that this won't migrate to other sites and cause thrombus, and after that we should do crib bandage, which should be kept for around 6 weeks.
So your intention is create a thrombus.
Yes, yes.
If you create thrombus, it will always recanalize. You are not going to get
We are sclerosing the vein.
sclerosing. It's not to produce thrombus. If that is why we are putting occlude the vessel. If the vessel is open and it will form a thrombus and it will recanalize. Okay. So you should bandage. It should be approximate. Then only the mucosa will be
acting with the
fibrosis will be taking place. Our intention is to produce a fibrosis, not to produce a thrombus.
Okay, sir.
Endophlebitis and fibrosis. That's our aim, not thrombus.
Okay, sir.
Apart from that, what will you do for perforator incompetence?
Stab
Foam
avulsion.
sclerotherapy,
Stab
stab avulsion,
Hook phlebectomy,
yeah, hook,
subfacial ligation,
subfacial ligation of
Seps.
cocket and
Seps.
Subfacial
And what is the best?
And the laser and RF catheters are also there.
Sir?
Specialized
Yeah,
catheters are there.
even, yeah.
Okay, sir.
That laser fiber, same you can use for the
Perforator.
perforator.
Okay, sir.
The same fiber which you use for GSV ablation, you can use for perforator. But RFA, you should have different,
Smaller catheter.
smaller thing. You need to.
Okay, sir.
So the best is stab avulsion.
Okay, sir.
Best method of treating the perforator is
Stab avulsion. Okay,
That's what Bailey says.
Okay, sir.
What is microsclerotherapy?
So it is dilute sclerosant. The 0.1% of 0.1 ml sclerosant is given to telangiectasia, reticular veins or thread veins using 30 gauge needle. It's microsclerotherapy.
Other uses of sclerotherapy from audience, apart from varicose vein, hemorrhoid, first and second degree. Then, never? Esophageal varices, rectal varices, then. And venous malformation. Venous malformation where it be intramuscular, you can use sclerotherapy. Name some sclerotherapy agents. Name some sclerotherapy agents.
Sodium tetradecyl sulfate,
That's what
3%.
Sodium morphate.
Polidocanol,
Sodium morphate can be used.
Ethanolamine oleate.
phenylamine oleate.
Yes, sir.
Can you use any glue?
There is a cheap drug.
Cyanocrylene glue can be used, sir. 0.1 ml.
What does it produce?
It causes thrombus.
Fibrous. Occluding the vessels
very
and causes fibrous.
Never our aim is to produce thrombus.
Yeah, correct.
Okay? Any thrombus is dangerous.
Any thrombosis.
So where do you put the glue first? Lower end or upper end?
Upper end. Upper end.
So what it will produce?
So occluding the
This
vessels.
polymerization. So what will be the feature? Late after doing the glue, what will we see? Suppose in the subcutaneous vein is there, thin individual. That will be persistently present there.
Cord.
Okay, sir.
It will be felt like a cord or something will be feel.
Superficial.
So what is your feeling now? You are doing much on the glue?
Blue is not my first choice.
Initially it had then there is slowly it is
Decreasing.
because of this persistence, complications, the cutaneous changes which is taking place.
Okay, sir.
What are the complications of glue? Two well-known complications are there. Glue.
Glue, what are the well-known complications?
One is it can produce allergy, severe allergy, drug allergy reported. Second is it's a cement-like material which will not get absorbed. Till the patient is alive, that cement will be there. It's a concrete-like material. It's a bridge. So a thin patient, a female patient, etc., they can feel it. So it's unless the patient demands, my personal choice is not blue. But it's a very common mode of treatment.
Okay, sir.
Okay, if this patient, okay, anything else? If this time, sir? Sir is very generous about time. Okay, but sir says it's very okay. If this patient comes out with recurrent ulcers after 2 years, what will you do?
Recurrent venous ulcer.
You have done a good life, sir. Patient has left home, left hospital happily. But after 2 years, patients come
How
with
many
a
percentage is the recurrence? What is the cause for
30.
recurrence?
Neovascularization and recanalization are two major causes for
What is the most common cause for neovascularization?
handling of the tissues.
Too much handling,
Handling.
around that area.
Yes,
So
We can.
Sir, 5 to 10 years.
So come back after 3 years to your OPD. saying that, doctor, you have done this job and ultimately my life is in trouble. Recurrence with ulcers and all those things. What will you do?
Recurrence, we can go for either open surgery or sclerotherapy can be done.
First you do duplex and assess the
Duplex and assess the.
Will you do an MR venogram in this patient?
Yes, sir.
What are the
In
indications?
chronic venous insufficiency, we can go for MR venogram to see lipodermatosclerosis and ankle, if there is any deformity at the level of ankle and ankle.
MR venogram. Indications.
In renal disorders,
Multiple recurrences
multiple recurrence.
and you're suspecting any iliac vein or IVC obstruction. In that case, MR venogram is important. Simply isolated leg lesions, MR is not primarily indicated. If there is single recurrence.
Can you clinically make out the iliac vein is involved or not when you are clinically examining the varicose vein?
Above the inguinal ligament, if varices are present in lower
We are not talking about superficial vein, no? That's the inguinal iliac veins are involved.
We can empty the veins.
You can empty the iliac vein.
No, sir. It will be having varicose veins, sir.
Okay.
So we can the prominent veins can be emptied, and if we take the yes, sir, the proximal hand, if we cannot milk the
You just elevate the limb.
okay,
Normal
if
vein
it is
will
not,
collapse. If it is not collapsing,
it is above the femoral.
femoral the obstruction is above.
Pathology is above
What
the
is the
femoral
other
line.
reason if it is not collapsing?
Obstructive.
One is iliac vein.
Iliac vein.
Second one is
Obstruction, pelvic
AV
malformation.
something somewhere there is
Fistulasis.
something arterial something is coming in. It is not, that is what not collapse.
Yes,
So that is one important test when you elevate when it is not collapsing.
Okay, sir.
Before writing up, any questions from the audience? Any
Yeah,
questions?
any questions from the audience? No doubt. So thank you, Ma. You have done very well. So
Yes, excellent.
you are from Tuticorin Medical College, you know. So hearty congratulations for an excellent presentation. So thank you for both the presenters, and the examiners will continue.